Hey y'all, hey, it's me, it's your girl Nurse T, Nurse T15, and I'm coming to you with another video. If you don't know me already, I am a BSN RN nurse. I currently work on a oncology med-surg hospice unit. I make videos about medical surgical nursing, or basically just anything that pertain to new nurses, nursing students, or if you're a new nurse that's new to bedside. If you've been away from the bedside for a while and you just kind of want to refreshing and kind of know, okay, what is it like being back on the med-surg unit, I'm the video for you. So anyways, today I wanted to talk about this topic. It rubbed me, slightly. I always encounter this type of stuff, but especially, let's say the last 2 days of working, I noticed this, and okay, so basically, I want to kind of go over some nursing 101 courtesy things that you can do to ensure that you're being a team player and that you just basically leaving a good impression behind when you leave after your shift is over. This could pertain to day shift, this could pertain to night shift. Just know that this is nursing courtesy 101, and a way that when you actually starting off on a unit, if you kind of keep these things in your forefront, it'll really be helpful. Like I said, this can be something that could pertain to you if you're working day or night. Overall, it affects patient care overall, period. All right, so the first thing that I would say, number one, is when when you're at the end of your shift, please make sure that you medicate your patients. So if you work on a floor where you have a lot of patients that complain of pain, and let's say that the patient is not in pain when it's like, if you work a 7A to 7P shift and you getting ready to leave at 7P, it doesn't matter whether, okay, well, if you're getting ready to leave at 7A or 7P, if your patient at 6 o'clock say that they're not in pain, but right at shift change, they call you and tell you that they're in pain, please be courteous enough to take care of the patient in pain before you leave. Because if not, then you have like the uncommon nurse that's still trying to get reports, still trying to start up the day, and yet they have to stop what they're doing and go medicate a patient. And it's not really about that. It's so much about the patient waits and they wait and they wait and they wait, and that kind of stuff really affect patient satisfaction scores as well. So if you're a person that's in a hospital and it's 6 o'clock and you start feeling like you're having pain, but all of a sudden you realize, oh man, it's shift change, and not only do I have to wait till shift change over, but now I have to wait till the new nurse completes whatever it is she's doing and starts her round and wait on me before I can, get some pain medicine. So please be courteous enough to, once you're through with your report, at least go back and give that person something for pain. The next thing I would say be courteous enough to do is, and although this particular thing can be split between the PCA and the nurse, it's usually something that the PCAs check before they leave, which is checking the patient's diaper if the patient has a diaper. But at the end of the day, it's all falls on the nurse. When they see that my diaper haven't been changed or this haven't been done, they're not going to ask for the PCA. They're going to ask for the nurse. So as a nurse, it's our thing to make sure that either A, we're informing the PCAs to check the diapers before they leave, or B, we go behind them and make sure that it's actually done. So making sure that the patient is comfortable, not wet, not full of before our shift is over. So be courteous enough to check patients' diapers before you leave. Not only that, as well as colostomies. So if you're not aware of what a colostomy is, it's usually a drain bag that they'll put on the abdomen if a patient has a colectomy or a portion of their colon removed, and they have to if they have to or sometimes if a patient have like some issues going on in the backside and needs to heal, they'll temporarily create a different route, reroute where the stool evacuates, and they'll put like a colostomy. Or if the patient have maybe colon cancer or anything that could have caused some type of damage to where they have to reroute the stool and temporarily or maybe permanently place a colostomy bag or an ileostomy bag, then please be courteous enough to make sure that's empty before the end of your shift. So I can tell you at least 2 or 3 times within the last 3 years that I have went in and seen colostomy bags about to burst. They look like balloons under the patient gowns, like about to burst. So the, be courteous enough to empty colostomy bags, because even if you try the slowest and the easiest as you can, depends on how the colostomy is placed. It depends on where is the opening of the colostomy. Some colostomies are 2 pieces. Some pouches are 2 pieces that you use to drain the stool. So if you have to detach it from like the stoma, um, it can be pretty messy, especially if it's very liquidy. So just be courteous enough to change the colostomy. And if you don't know what a colostomy is, I'll try to insert a picture of a colostomy bag to show you what it looks like. Also in that category, Foley catheters. The majority of the time, some patients, especially on heart failure patients, we have what's called I's and O's, intake and output, and patients have colostomies. Not colostomy, Foley catheters. So those patients, Foley catheters need to be drained at the end of the shift, and it helps the physician know how much the patient is accurately putting out. So we're supposed to record how much they're taking in, and then in return, we also see how much they are putting out. So countless of time I've seen Foley bags. You have about a good 2,000, 3,000 cc's in that bag, and that bag looks like it's about to bust. You know what I'm saying? If you don't empty those bags, the urine travels back up the line, and it can set, it's set in the lines, and it goes back to the bladder, and it put the patients at risk for infections. So always making sure that we are emptying those Foley catheters, as well as any other drains that the patient might have. Patient probably had a procedure where they have a drain, Jackson Pratt, a hemovac, certain particular type of drain, a Penrose. Certain particular type of drains are used to drain certain things, blood, whatever fluids that might be leaking from the body. A lot of y'all are familiar with even Jackson Prats, because that's the little bulb drains, or hemovac drains. I know BBLs are common, and after a BBL, some patients get drains put in. So those are the drains that I'm talking about. Well, I worked on a neurosurgery unit, so a lot of our patients had drains. The current unit I work on now, we still have patients that come back from lap choles, cholecystectomies, where they have gallbladders removed and all this other stuff, and depends on if they have to do an open or laparoscopic. It could determine if they have a drain at the end, and if they have a drain, we have to empty it. If not, like I said, it can bust, for one. For number two, and it's also about just properly documenting the output for your shift. You'll be responsible for that as well. So yeah, another thing to do is just kind of learn your patients. Sometimes we often just go to work, give meds, and some nurses are good for just kind of like not even taking the covers down to see the patient. I've been given report before where I was told that the patient ambulates, they walk or whatever. I go in and I pull the covers back. Patient have no legs, or I've been, it's just different things. Make sure you know your patient, because that can really make a difference when it's time to, like, if you tell me the patient been up doing this, that, or whatever, and then I try to get them up and then they hit the floor, we got a problem. If you tell me the patient is alert oriented ×4, move all extremities, vital signs been stable, this, that, or whatever, and then I go in there and all of a sudden the patient, and then I'm like, or if you're talking to the patient and they just looking at you, and you want to know, is there a change in the mental status, or has this patient been like this, and you don't know the correct assessment for this patient. Because if you tell me this and then all of a sudden I'm seeing this, I'm going to be wondering, has the patient had a stroke? Is the patient something going on with this patient? So please accurately assess your patients, and then you kind of know that wherever you kind of get the baseline. So if you walk in and all of a sudden your patient is not doing what these folks said that this patient can do, then you know it's time to call the doctor. Another thing for this video, and again, I'll keep my video under 15 minutes and I'll make this a part 2. But another thing, and I'm gonna say this again, another thing with this, and I think I will turn this into a part 2 because I'll keep it as this. The last thing on this video is, please make sure you check the patient IV before you leave. Again, and I'm gonna elaborate on this one. That's why I'm gonna go ahead and turn this into a part 2 after this. But yeah, please make sure that you check your patient IVs before you leave. I've came into situations where IVs were bad, and patient is sitting there getting stuff through their IV, and the whole time they complaining of burning, swelling, and redness. And the IV, when you get in there, it's like the arm is just infiltrated. Be courteous enough to stop that machine. Don't sit there and tell the patient to go through the pain. Stop the machine, stop the IV machine, take that IV out, and please document that and go get another one. Don't make that patient suffer. Not only that, having an appropriate IV can be very important, because even in situations where you start in your shift, you know the IV is bad, and you know that, okay, well, the person behind me didn't restart another IV, but I need to add that to my list of things to do, you know, during my shift, which is typically okay. But sometimes you got to expect the unexpected. It can be the unexpected that can happen. You find out from telemetry calling you that, hey, your patient is reading asystole flatline. And so then you have to go in there, and all of a sudden your patient needs resuscitation. So you have to realize that a part of ACLS, there are medications that you give to resuscitate a patient. You can't give those medications if the IV is bad. Keep in mind, you were supposed to do it on your shift. Once you settle down and got to that patient, you was going to do it. But this is the time, it's an emergency now. So always make sure patients have an accurate working IV. That's very important. Very, very, very important. Because you just never know. That person can be penning a test. And if that patient have to go down for a test, like an MRI, a CT, and they have to shoot contrast through there, and they don't have an IV, a lot of times they'll get upset. They'll call back. They'll find out who the nurse was. They'll write the nurse up. They'll do what we call a patient safety report. You know, they'll write it up. So just make sure, because the oncoming shift that's supposed to be accepting that new patient on their shift, think about when you start your shift. You don't want to start your shift off with starting IVs at the beginning of your shift. It's okay if it happened throughout the shift, but if you knew that before you left that they was going to be talking about that IV either leaking or it's infiltrated, please be kind enough and go ahead and stop that IV and put a new one. But I'm going to stop it here. Let me know if you like this video, if you want more of Nursing Courtesy 101, some things that you can kind of expect, or have your little notebook pad. You're getting ready to start, you're getting ready to graduate this year, and you just kind of want to make sure that when you starting correct. You know, when you start, you just kind of want to keep a journal of what are some things that I've seen that I know that I don't want to do, or some things that I've heard that got other nurses in trouble and I want to avoid that. Well, that will also be another video for me too. A video that I will make that will kind of give nurses, new nurses especially, an idea of things to avoid to prevent write-ups. I'm a firm believer that if you know, I try not to make mistakes, but mistakes can happen. You know what I'm saying? I can accidentally unlabel something, mislabel something, whatever. It can happen to anybody. But the decent thing about someone else telling you that it happened to them is that sometimes it's best to learn from someone else's mistakes. So I'll make a video on things to do to prevent write-ups as well. But I'm going to go ahead and end it here, and I'll see you on the next one, on part 2.